couple minutes. I screen shared the Romatouche Aloni land acknowledgement just so that everyone could look at it while we were waiting. I won't spend time to read it out loud. Hopefully you all had a chance to look at it, and I will stop sharing now and just say we are so excited to have Dr. Chris Stewart here to speak to us today, and he had requested that he introduce himself. So I am just going to turn it over to him for the rest of the hour. Thanks, Chris. Oh, Chris, you're on mute.
Hey, sorry everyone. I just got a nice new computer that shut down on me, so I'm on an old one that luckily I still have. And I'm just going to try and get my slides up quickly. Let's see if this works. Does that look okay? All right. Thanks everyone for joining. My name's Chris Stewart, and I've been at SFGH for about 25 years, and one of my clinical specialties is child abuse, which I've been focusing more on in the last 5 to 10 years. I also have done a lot of international global health work at UCSF and really have enjoyed that work. But today, wanted to talk to folks about medical child abuse. So title of the talk, 6 things you should know about medical child abuse. And I would be happy if, Sean, if you get anything in the chat, and feel free to interrupt me with questions. I don't think this is going to go the full time, or certainly there will be time for questions. But I'd like us to recognize by the end of this, at least, have gone over and given folks a chance to have in their mind a way to recognize some of the concerning presentations for potential medical child abuse, and understand at least a couple strategies to address this really difficult type of child abuse, and list some possible ways to prevent it. And so the first question is why, the first thing you should know about medical child abuse is why do we call it medical child abuse? The definition is a child receiving unnecessary and that red and is not in the original definition, but I put that in there to emphasize that receiving unnecessary and harmful or potentially harmful medical care at the instigation of a caretaker. So many folks know this entity as Munchausen's syndrome by proxy or Munchausen's by proxy. There's a number of other names, and generally in psych, they tend to use some of these different terms. Pediatric condition falsification, factitious disorder by proxy, and there's others. But one of the big researchers of this, Carol Jenny, who's now retired but is a big publisher in child abuse literature, and she really studied this entity a lot. She kind of coined this term medical child abuse rather than Munchausen syndrome by proxy, because the key in her mind was looking at the harm to the child, not the psychopathology of the caretaker. So Munchausen's by proxy was a term that was coined by a British pediatrician named Sir Roy Meadow, or he was knighted to be Sir Roy Meadow. And Baron von Munchausen was this baron that told a lot of stories, kind of bent the truth to tell these exciting stories to folks. And so by proxy is getting that through someone else, and in this case, the parent would potentially be telling stories through using their child. But the confusing thing often in these cases was then having to describe and maybe even if they went to court, prove this psychopathology of the caretaker, rather than just looking at what's happening to the child, the harm that's happening to the child. And so the term medical child abuse is used in my field because it's a lot easier for folks to understand kind of what the issue is and how to address it. Carol Jenny in the article on this page kind of looks at medical child abuse as similar in some ways and opposite in others to medical neglect, where in neglect parents aren't providing, they're omitting important medical care, other things that are necessary for the child to be healthy. In this case, parents are instigating or pretending that the child is unhealthy and not worrying about the reason for that. In both of those is not worrying about the intent of the parent is an important thing when I go into these cases, either severe neglect cases or these medical child abuse cases. There may be clues to that, but that's not something that we're focused on proving. So the types of harm that come up in these cases include unnecessary testing, painful unnecessary procedures, including sedation, radiation, procedures to, anesthesia for various procedures, social isolation, for example, removal from school, often in these more severe cases, being confined to a wheelchair or having other such kind of isolating and socially distancing behaviors by the caretaker. And then psychological harm like PTSD from repeated hospitalizations or trauma from procedures, and identification of being a patient. So those are just some examples, and as we'll talk about a little in maybe some of the extreme cases, you can see that there's other types of more extreme harm potentially. So the second thing I want folks to know is that medical child abuse is a spectrum of behaviors, and there really are cases from mild to severe. And a mild case may be a parent who's super anxious and brings their child in constantly for something, even though they are reassured that it's not a concerning issue. They might keep bringing their child into the clinic to say, check this cough, or look at some rash that seems to be bothering the parent but may not be bothering the child, or of real significance. And that does expose the child to potential harm in terms of getting infections in the clinic, you could argue, and but it would be on the mild side. Whereas very severe cases, you might have parents actually, the types of cases you probably think of when you think of Munchausen syndrome by proxy, where a parent is actually creating illness in their child. For example, injecting feces into their lines to make them sick, or smothering them to make them have what appears to be acute life-threatening events. So I'm just going to give an example of a more severe case, just to bring up a couple of points about this. And this is a case I had maybe 5 or 6 years ago, where initially I was consulted by a surgeon for a child that was TPN dependent and had multiple specialty providers. They had been diagnosed with a number of unusual conditions which really weren't connected or it was hard to see any unifying diagnosis, but the conditions were led them to be seen by multiple specialists and had led this child to be TPN dependent and wheelchair bound. And the surgeon called me because the stoma the patient had presented in a way with their stoma had been pushed in a way, it had presented in a way that seemed to be unusual, and the surgeon, who usually are not the specialties that bring these cases to my attention, but this surgeon was concerned about the way this stoma presented and thought that it may have been manipulated. And our team took this case and reviewed it and looked over various aspects of it and saw multiple diagnoses not connected and rare diseases, and saw also this previous PICU admission where the patient had come in severe metabolic acidosis, but no infection had ever been found and no clear reason for that had ever been found. And we suspected medical child abuse. We actually made a report to CPS, but at that time CPS did not intervene, and we'll talk about why that might be a little later. But on their second presentation, they ended up back in a pediatric ICU in another hospital with severe metabolic acidosis, and were referred to us because they had gotten a CT scan which was read there as having subdural hemorrhages, and they had made a second CPS report. And when we saw the child, we reviewed the imaging and didn't think there was subdural hemorrhage, but the specific brain findings here you can see lighting up symmetrically, and the areas where this MRI lit up were very concerning for some underlying systemic disease, definitely consistent with mitochondrial disorders, and the presentation could go along with that. But the neuroradiologists we were working with brought up thiamine deficiency as one thing that this really looked like. And when we tested the patient's thiamine level, it was extremely low in the setting of this acute illness. And after they were supplemented, it went up to normal values. And as I reviewed thiamine deficiency, vitamin B1 deficiency, beriberi, there was a certain type of this, a certain subset. I think folks may remember dry and wet beriberi and from way back, or if you've done international work, or some of our family medicine colleagues may come across thiamine deficiency in the setting of alcohol abuse. But in this case, there was a certain subset of this, which is called Shoshin's. It had a special name, but presented with metabolic acidosis. And with this fact, we were able to. The mother insisted that she had been given the TPN, and we were able to go back to CPS and kind of prove that she was lying, that she hadn't been given the TPN, because it would have been impossible for her to give it and for this child to have this vitamin B deficiency. Because when you give TPN, you give vitamins, you're taught to give vitamin supplements as part of the TPN administration at home, and we had mom kind of caught in a statement that she was doing that and that there was no break in that. And so that was very helpful in then going to court and showing that this was a case where mom had actually not been given TPN And the patient eventually showed up with this thiamine deficiency, which looked like a very severe sepsis in the PICU setting. So another thing that I want you to know that comes a little out of this case is that medical child abuse patients may have actual illnesses, and that makes it very difficult to prove that some are fictitious. It's often these aren't particularly illnesses or diseases, but say an aberrant subclavian artery that is found early in life. And so there is an actual abnormality. And so when you're trying to convince outside lay people that the mother might be fabricating other illnesses, they will point to, oh, but there is these actual illnesses, and it makes it much more confusing because it's not a clear cut everything is fabricated. And so it's an important point to, when I'm talking to folks who may be investigating these cases, to have them understand that you can have both real medical conditions and then have this overlying medical child abuse at the same time. There's a lot we don't know about medical child abuse. We have some. There's a number of studies that have tried to look at incidents, and this is generally thought to be fairly rare. You can see 1/2 to 2 cases per 100,000 in less than 16, and it gets greater in younger children. And it seems that males and females are equally affected in what we know more or less today, and that the mean age, it usually affects younger children. The mean age at diagnosis is somewhere between a year to 3 years. And the mortality rates can be quite high. So here's really one of the more important take-homes from this talk is what might give you concern for possible medical child abuse? What types of things should put this on someone's differential? One is the diagnosis not matching the objective findings. And you can imagine that often happens in medicine for us when we have this textbook idea of how something's supposed to present, and it never, strep is an example where it can mimic all types of things. And so this needs to be taken when a diagnosis doesn't really match what you're seeing. Often what I'm talking about here is for example, a parent might say that the child is totally intolerant of food, but whenever they're in clinic, you see them wolfing down French fries. That would be, so this kind of diagnosis of some type of food intolerance may not match what you're actually seeing. The other is inconsistent histories or signs and symptoms present only in the presence of a single caretaker. There was a case I had at Mission Bay a while back. Some of you may remember that case where this child had been seen at a number of clinics and then had been admitted a couple times to Mission Bay for workups for apneic spells, kind of desaturations and apneic spells, and maybe potentially some seizure activity. And as we looked into this case, even though a emergency room doctor said they saw the desat into the 70s, when we really looked at it, that doctor had gone into the room after the SATs were way down and the patient was with the mother. And we consistently found this, that the team on the ward was often called to the room and the SATs were down in the 70s, and then they would come back up and the child was kind of resuscitated, and then everything was fine. But as I looked through, the symptoms were only presented when the caretaker was there alone. And that was a big clue to that case, which we eventually actually videoed, did some video to catch the mother smothering their child to cause these episodes. Another concern would be failure of the child's illness to respond to normal treatments. And again, the idea that you do normal treatments and then the symptoms are still reported by the parent, and that would be, might get you thinking, that's not the usual thing we see. The caretaker insists on invasive procedures, so when given a choice, they're tending to want the more invasive or more looking for more investigation, more tests, and they don't express relief or pleasure when they're told that their child doesn't have a particular illness or when they improve. So you would think most parents would be happy to hear that, and often these caretakers would somehow be more argumentative or looking for some other, again, pathologic cause. Sometimes the caretaker themselves or siblings of the patient may have a history of also these unusual or unexplained illnesses. And then doctor shopping, I think folks have heard of that term, where someone may go from one provider to another to get second opinions or third opinions or fourth opinions and continue trying to get diagnosed with particular illnesses. Some other clues that or some things that are associated with this as well are that the signs and symptoms reported are difficult to verify by providers. And I gave the example of seizures and apnea. Pain is another one where a parent can say this child has pain, and it may be difficult to in the office, kind of in the primary care setting, to evaluate that. Feeding intolerance, food allergies, vomiting and diarrhea, these all are types of symptoms that are more difficult to, especially in the outpatient setting, to verify by medical providers. And because of this, you can imagine the types of specialists that are likely to see these patients are GI, cardiology, rheumatology, pulmonary, neurology. I mentioned the PANDAS clinic. I run a program at Lucille Packard, Stanford, and there they have the only panda clinic in the country. And our team feels like this is a magnet for these types of patients. And we've had a number of them that come through that clinic where we have gotten involved. So the diagnosis of medical child abuse can be difficult and often requires a thorough review of the medical records, and often requires going back and meeting with providers and sometimes even teachers and others in the child's life to get more information and kind of get a sense of if what the caretaker is reporting is actually what is seen out in the world outside of our medical offices and wards. When we're looking at the diagnosis, again, the focus should be on the harm to the child and not thinking about the profile of the caretaker. Although often it seems that there may be some gain, some type of gain, or some motivation for the parent, and that may be monetary in terms of having a diagnosis which allows the parent to get funding or some type of support through their child. Or it may be, and this is the classic Munchausen's by proxy profile that Sir Roy Meadow described, a parent that seems to get a lot of attention and is often enmeshed with the medical system. And the classic profile is often a female caretaker who has some medical background and can be quite enmeshed with various providers. One of the doctors at Stanford told me that when she referred a patient to me, her aha moment for realizing this patient, which had been confusing her and making her concerned perhaps about this diagnosis, was when she looked at the screensaver on the Stanford LPCH website and saw the patient's mother there with some nurses kind of all together. And that just, this patient had been so much on her mind, and that just made it click to her that, wow, something's really going on here. And we ended up actually getting involved in that patient and proving and demonstrating that the mother was in fact injecting feces and saliva into the lines and causing infections in the child, as well as had probably been using blood that was not the child's in photographs to try and show that they had bleeding from their nose or mouth that was worked up a lot, and there was no cause ever found. So this is something, the last point, that the average time from symptoms to onset to diagnosis is 1 to 2 years, is an important one. There are reasons you can imagine why this diagnosis takes so long and is often missed and or ignored. And one of those is that, of course, none of us expect caretakers to lie to us. And we generally, pediatricians are trying to, do good and make and work and help children and do that with families and support families. And so the idea that you're being lied to is really not something that's in the mind of most providers. And we generally will take things at face value if you're not a child abuse pediatrician, and you'll be very trusting of the caretakers. And then it's just not on the radar. The diagnosis itself may be really not something that they've heard much about. The other issue is that often specialists are dealing with these children in isolation. So one provider is dealing with a G-tube, another is dealing with a very rare blood disorder that they're working on, and no one's connecting that there is a GI issue, a cardiac issue, and maybe a neurological issue that all seem kind of strange and unusual. But none of those specialists are talking to each other or realize that there's a pattern. The other thing that comes up, I think, a lot is that when there are suspicions, people are reluctant to address these cases because it seems like there's an overwhelming amount of information and it's hard to know what to do. And so it's easier kind of to just have some suspicion, but not enough to do anything. And so just do your best and keep working with the parent. And there often isn't enough to actually make a report or a report where action will be taken. And as I said, investigating takes time and resources. and often confronting the idea of this is is done or comes up with an already very challenging caretaker. Many of the caretakers involved in these cases are ones that providers would say are challenging for them. And so to then, when pediatricians often aren't confrontational anyway, to confront someone that's already very challenging is something they may shy away from. And then there's been cases in the news where there's lawsuits around investigation or reporting of medical child abuse, and that may have a somewhat chilling effect on getting involved. When I think of one of these are three questions I often kind of ask myself as I'm asked to evaluate one of these cases. First, are the history, signs, and symptoms of the disease credible? And we went over in some of the points that might raise our suspicions whether that's true. So are things responding the way you would think? Are the descriptions of an illness the way you might think? Is it only seen in the presence of one caretaker? Is everything dependent on the reporting of the caretaker, and there is little objective signs or no objective signs of these symptoms or signs? So those would certainly be, that's one first question I'll look at. And then, is the child, because of this, receiving unnecessary and harmful or potentially harmful medical care? Because it's the harm part that is really the abuse part. And if so, who is instigating this, the evaluation and treatment? So are the doctors pushing for more and more investigation, or is it really the parent that's leading that, or the caretaker? So those are questions that kind of help me get a sense of whether this is more a case that's quite concerning and to go forward with it in that way. Many of these cases might, I say, if it's not meeting your reasonable suspicion threshold, that's kind of my code word for saying if you don't think you can make a CPS report, or if you think it's unlikely that a report will be made. Yikes, I'm gonna have to, sorry about this. I'm gonna be moving while I'm talking because my computer's running out of power. So there are things we can do if we can't, if it seems like a report can't be made, or if a report actually is made, like I mentioned in that one case. Excuse me. So if a report is made and that the CPS doesn't take it, there are things that we can do to stop the medical system ourselves being the instrument of abuse. Because in medical child abuse, really, we, or the medical system, is the instrument of abuse that the caretaker's fabrications or lies cause. And so the general things that we would do is try to communicate better among specialties, to triangulate information, and to document concerns. So the next two slides, again, are an important thing to think about in this entity to address potential medical child abuse. So the first one is verify the caretaker statements whenever possible. So if the parent says, my child was diagnosed with this rare disorder, down in UCLA, rather than just saying, okay, and putting that diagnosis in the chart and just accepting that. If there's some suspicion of medical child abuse, then calling up UCLA or getting the records and trying to see exactly if that's true and how, how that diagnosis came about. So once the suspicion is there, having the various providers do that can be very helpful. And then once those, if there are misleading statements or frank lies, putting them in the chart without judgment, but kind of objectively. Mother said this, and I checked and found out that. And I find in these cases, often when they've been going on, the concern or suspicion has been going on for a year or longer, people are often talking about it and saying that they have suspicions, but nothing is documented in the chart. And so they're looking for these actual objective misleading statements by verifying and then actually documenting it is super important, because otherwise it really, that information can't be helpful to protect the child if they end up going to court through child welfare system. When we do this, often when we're investigating a case over time, and it's moderate to severe case, we want to avoid tipping off the caretaker if there are concerns, but we're still gathering diagnostic information. And that may be accomplished by using confidential notes, whatever your institution uses as exception to cures, and so that the parent doesn't know that there is an investigation or that there is a concern. In the cases I mentioned of the smothering, the baby that was being smothered and we eventually caught on video, it was important not, to make that diagnosis, not to let the parent know that we were concerned, or it would have been more difficult. And that's generally true for the more severe cases I have. The other thing we can do to try to minimize or mitigate or stop potential harm to the child is be wary of agreeing to further test procedures or other interventions based solely on the caretaker's wishes and reports rather than on objective data. And this is, I think, sometimes in these cases where I have where the suspicion comes, what we'll call together a meeting of all the specialties involved, and it's very revealing to many of them to hear that this child has, that the concern is not just theirs, but that many other specialties have similar concerns or similar concerning behavior by the caretaker. And they are, I think they feel, the providers often feel supported and empowered to have better boundaries and say, no, we're not going to, we don't advise this, and we're not going to do this. We're not going to put in this G tube, or we're not going to go to TPN, or we're not going to do this MRI. It's simply not indicated. And then avoiding specialty to specialty referrals. A lot of these patients, if you go back in their history, the reason that they often get kind of removed a little bit from their primary doctor, and they end up going from one specialist to another, so they have a whole cadre of specialists, and the parent will often latch on to one of those specialists who they feel supports their vision of the patient and the world. And there, in those cases, when we suddenly try to have all the specialists refer back to a primary doctor, or if the primary doctor is the primary doctor may need some support and education around the potential diagnosis, then that can be very helpful to prevent further harm to the child. So I mentioned diagnostic video, or it's sometimes called, well, diagnostic video is a term we like to use. It's usually done without the knowledge, not usually, it's always done without the knowledge of the caretaker. And it can be helpful, as I mentioned, one case I had with that smothering where the mother was smothering the baby. We did actually do that video and catch the mother smothering the baby. But that is very expensive and you need real clear protocols. You can do it ad hoc, as we did in that case over Thanksgiving, but it was a lot of work. And as you can imagine, you have to have the leadership of the hospital, legal involved, the police involved, and CPS involved. In those cases, we monitor the video 24/7 so that there's not a bad outcome while we're videoing the patient. And so I mentioned Carol Jenny, who's one of the leading researchers on medical child abuse in the country, and she's at University of Washington, where they probably do 3 to 4 diagnostic videos a year, they say, and they have a nice protocol for that. But she thinks that she's kind of against diagnostic video, and her point is that we don't do this for other child abuse cases, and really you can make the diagnosis without it in most cases. And the case where I described a mother smothering their child both in and out of the hospital to create these symptoms of apnea and possible seizures, I would have been able to go to court and make a strong case for that being medical child abuse without the video. But as often happens in that case, of the specialists, I think 12 specialists that child was seen or had been seen by in the hospital, the neurology team had gotten an EEG that showed some slightly abnormal spikes, and they thought that this was consistent with a recently described familial seizure disorder. And that's what they thought the diagnosis was. And they were actually quite against us doing any diagnostic video. And so in that case, the defense attorneys may well have had them on the other side if that had gone to court without the video, saying we think this is probably more an actual seizure disorder. Whereas stepping back, it seems so obvious, and in hindsight even more so, that these symptoms only occurred when the caretaker was there, and seemed to occur more when we talked about discharging the patient. They would suddenly pop up with lots of these, and yet never occurred over the 3 days of video EEG, when the caretaker knew that the video was being done. If we do report to CPS, there are ways to make those reports more successful, and this applies both to medical child abuse and neglect cases. You really need to give clear explanations of the problem in understandable language. You can imagine in these medical child abuse cases, they have all these unusual diagnoses. And so using medical terms, it just immediately a judge or jury or a CPS worker will get totally lost in the weeds and not really see the big picture. So trying to explain things in a way that a layperson can understand. You have to list the harm or potential harms to the child. You have to make those clear. because if there's no harm, then there's really no abuse in a way. And you have to describe what's already been done to address the problem. And that comes up a little in medical child abuse, much more in medical neglect, where you really need to address any barriers that the parents may have in terms of language, culture, transportation, things like that, that the hospital or healthcare team should be able to address before having outside like child welfare support. The problem with relying on child welfare in these cases is that there's often very confusing, as I said, and often hard to prove the caretaker's role. And so what we can do is, in these moderate extreme cases, where we can report to CPS, but the other options are to use the strategies I mentioned as an institution and do the, I often will write out when I have a case, I'll write an email or have a meeting with all the providers and go through what medical child abuse is, and then here's the strategies we all need to do. No specialty to specialty referrals. Make sure you have a skepticism of the caretaker's reports, and so try and verify information, document things, and those types of actions can help our institution not to continue to be part of the harm to the child, even if CPS doesn't take the case. Now, it is certainly true that the parents, and this is often the case, or the caretaker may go to another institution, and I'll talk a little about some options there. Often, or at some point during most cases, we'd have a meeting with the caretaker, and the goals of the meeting would be to kind of detail the medical condition of the child, dispel any false claims or alternative medical conditions that the caretaker may be espousing, and then express the concerns about the distorted perception of the child's health and focus on path forward. That sounds all nice and easy. It often isn't. A parent's reaction in a meeting like this will often be a clue to the prognosis or the likelihood of the child being able to thrive with that caretaker in the future. And I'll show you a couple of other things related to that. But in the case of a very mild case, I might suggest that the provider have this meeting with the parent early on and just talk about, I notice you're coming into clinic all the time for this cough. We've gone over this. We don't need to investigate it further, and kind of try and figure out what's concerning the parent, and maybe they need support for their own anxiety around this and may be willing to engage in that. Versus in the more severe cases, this meeting is often after a report's been made, and we do it with child protective social workers and folks in the room with the parent and the whole medical team to go through this as well. And then other possible ways to prevent further harm to children if child welfare won't or can't be involved is communicating with other hospitals is another thing that is that can help, so that the child doesn't get then just go to UC Davis and get a whole nother workup. At least if they try and get referred or get a referral to another specialist, as one would normally, you might share information with that specialist to specialist about the case. And this type of communication can be very helpful, just to prevent further harm. Another thing that we're about to start instituting at Stanford, and I think we'll be coming here to UCSF soon, is using a committee within the hospital to review cases so that when a case comes to attention, it would first go to the child abuse pediatricians who might screen it out, and if it seems like a more concerning case, would go to a committee where that includes members of say GI, neurology, other specialties like that, who can review these cases and track them over time, because they do take a lot of work, and it is in tertiary or quaternary referral hospitals. These cases are often a big drag on the system. So having a way to manage them and address them with multidisciplinary committee can really uh, help the diagnosis or interventions continue, and the final intervention potentially by child welfare system occur earlier than would usually be the case. I'll just treatment for these cases includes for the child physical and psychological treatment, often has multidisciplinary with specialists, and when we are clear that the diagnosis, when we're pretty clear about the diagnosis, we usually discontinue therapies quite quickly, reintroducing foods, getting out lines and getting out tubes and things like that quite rapidly while under supervision. There is obviously psychological treatment for the child is important, and the caretaker also, if they're able to engage. These are some factors for a more favorable outcome, including positive input from the spouse or grandparents rather than aligning with the caretaker, successful short-term foster care before returning to live with offending caretaker, the offender's long-term therapeutic relationship with social workers, successful remarriage of the offending caregiver. These have just been associated with better outcomes. Early adoption of the victim and long-term foster care placement. And for the offender, ideally, if they admit the abuse and have been able to describe how they abuse the child, they're more likely to have successful treatment. And these are some other things that may be helpful for the offender. There's a lot to study in this. There's a lot of gaps in our knowledge about MCA. There's many case studies out there. I just did a review with some surgical colleagues, and we were looking at, are there particular surgical presentations that anesthesiologists or the surgical folks should clue into. There's less epidemiological studies. There's questions to me, for example, does earlier intervention in milder case prevent progression to mild to severe cases, and how that, what are the best interventions? And then also, are there certain combinations of data points that could flag cases? For example, if a child has this combination of diseases or a certain number of specialties, could that be a flag that then automatically has those cases reviewed? Some institutions like University of Washington has a protocol where before they put in a G-tube, they have a little checklist and screening for potential, is this G-tube really necessary, and is it based just on the parent's report, or is there some objective data for that? Because many G-tubes are just kind of put in easily and without much, with just accepting the caretaker's description, and that's a question of whether that's an effective strategy. And I think it's an interesting one, but it's not clear whether that's actually preventing medical child abuse. But those types of things are interesting for future study. So just a quick recap. it's medical child abuse, not Munchausen's by proxy or other names. And the reason is we're focusing on the harm to the child, not on the psychopathology of the parent. There are mild to severe cases, and you can intervene in all of them. The strategy may be different for the mild versus the severe, but there are things we can do to help prevent further harm to the child, even if we can't take these cases to CPS yet. And often the child has actual diseases or abnormalities as well within this diagnosis, and that's important to explain to others, because that is something that many people latch onto as, well, they actually are sick. They actually do have this objective illness. There are key red flags for suspicion that you should know, and there are strategies to prevent further harm, even without CPS or child welfare system. And if you're making a report, make it clear to a layperson, something that they can understand. It really is a multidisciplinary response, and this is particularly one of the entities where, as a child abuse pediatrician, I get consults for these cases. Can't do it alone. Need the whole team, need specialists, all to work together to try and help these children. I will say, when these cases do go, severe cases that end up protecting the child, they can be incredibly satisfying. The case I mentioned of the thiamine deficiency, where the child was wheelchair bound, TPN dependent, never in school, was actually also on large doses of narcotics. By a few years later, she's is working through some psychological issues, but is thriving in school, independent of any TPN, not in a wheelchair, on almost no medications, and so really is a turnaround for that child's life, dramatic turnaround for that child's life, because of the recognition of a couple providers that really were willing to say, hey, this isn't right, and made the referral.
Thanks so much, Chris. As Anda said in the chat, it's a condition that I think doesn't get enough attention, and I think people feel really unsure of how to proceed. So this was really helpful. I want to be mindful of time. It's 9:03. If you
I'm sorry. With the
no,
computer change, I couldn't see
worries.
the clock.
If people need to leave, please go ahead. And Chris, if you have like a couple minutes, I do want to give the opportunity if you could do like 1 or 2 questions for those that can stay, if anyone has one.
And and everyone knows, or hopefully you know me, or if not, feel free to email me anytime. There's a Chris Stewart that's an orthopedics resident. Please don't email him.
Awesome. Okay, so people know how to reach out to Chris, and then if anyone has a question, we can do 1 or 2.
Question is Raul.
Great, go ahead, Raul.
So, hey, Chris, thanks so much for doing this. So I feel like there was a lot of media attention, or at least a little blip of media attention on medical child abuse, like maybe 2-3 years ago. One a particular case, I think in Texas, where there was some criticism about the diagnosis being too broad, the potential for missing rare diagnoses that I think you covered on, and not fully integrating the kind of parental disposition, I guess, particularly for those parents or caretakers with kids who do have rare diseases or had like prolonged NICU stays, and had this kind of framing of not being trauma informed enough on behalf of the parent, in that there were many parents who were hyper vigilant, or having kind of trouble transitioning from that really sick phase to the kind of improving phase, and that any symptom was like a trigger for hypervigilance on behalf of the parent. I'm wondering if there have been more like studies around those ideas, or kind of what your thoughts are around that.
Yeah, I think there's been, I think that the main thing I'm aware of with those is that they're certainly among colleagues, I think people are nervous to take on these cases because often the parents tend to be the type that comb through the record. They are aggressively challenging to the medical community. And on the one hand, as you say, that's, they I think there's less study on it, but it has brought concern to many child abuse pediatricians about how to address these cases. And I don't have, I think really the best thing is to just focus on the harm to the child. And if that can be demonstrated, then not blaming or assuming anything about the parents' motivations, maybe mental health, maybe just their true beliefs about illness. I think again that idea of really looking at what's happening to the child is the only kind of take home point for that. But these cases have been in the news, like many cases end up in the news, shaken baby syndrome and things. And I will say, whenever things get in the news, it often doesn't tell the whole story because the institution can't give their side of the story because of confidential or protected information. And I'm just aware of that in many cases of this and other child abuse that make it into the news. But I think your point about you know trauma-informed care in these cases is super important, because often the caretaker, the reason they're doing this is because of their own trauma. Thanks for bringing that up, Raul.
Any more questions? Okay, awesome. Thank you so much, Chris.
Thanks, everyone.
Yes.
Take care.
Have a good day, everybody.
Okay.